Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I will be discussing a very important topic in the neurology, that is the neurocutaneous markers. So what exactly are these neurocutaneous markers? These are the disorders that affects the brain, spinal cord, right, and skin and as well as bones. Right, so these are the neurocutaneous syndromes or the neurocutaneous markers. And the diseases are lifelong conditions that can cause tumors to grow in these areas. So the tumors, they grow in the brain, spinal cord, skin and as well as bones, and even other organs are also affected. And what exactly will be the problem because of this neurocutaneous syndromes? The presentation of the patient or the individual will have involuntary movements, that is seizures, and there can be also developmental problems as well as the hearing loss. Right, so these will be the manifestations of the neurocutaneous syndromes. Now, if you see what exactly are the neurocutaneous markers, so all of the following are the neurocutaneous syndromes except neurofibromatosis, tuberous sclerosis, von Hippel-Lindau disease, Cowden disease, ataxic cerebral palsy. Now, among these, your Cowden disease is not the neurocutaneous syndrome, whereas what exactly are the neurocutaneous syndromes or neurocutaneous markers? Neurofibromatosis is one of a neurocutaneous syndrome, tuberous sclerosis, then von Hippel-Lindau syndrome, then we have what is called Sturge-Weber syndrome. Right, then we have what is called Sturge-Weber syndrome and as well as ataxic cerebral palsy or the ataxia telangiectasia. So these are your neurocutaneous markers or the neurocutaneous syndromes. Then what exactly is this Cowden disease then? So Cowden disease, if you see, it is a disorder which is characterized by multiple non-cancerous tumor-like growths. Right, multiple non-cancerous tumor-like growths, and multiple non-cancerous tumor-like growths, they are called as the hamartomas. Right, they are called as the hamartomas. And these individuals with the Cowden syndrome, they are at increased risk of developing certain cancers as well. That is what will happen in case of the Cowden syndrome. And almost everyone with Cowden syndrome develop this particular hamartomas. So basically, Cowden syndrome, it is a disorder characterized by multiple non-cancerous tumor-like growths called as the hamartomas. Now, these are the common neurocutaneous syndromes. Right, so what are those examples? Neurofibromatosis type 1 and type 2, tuberous sclerosis, ataxia telangiectasia, Sturge-Weber syndrome, and then followed by that von Hippel-Lindau syndrome. And the less common neurocutaneous syndromes or the neurocutaneous markers are incontinentia pigmenti, then basal cell nevus syndrome, then we have Bonnet-Doshon-Blanc syndrome, neurocutaneous melanosis, then we have progressive hemifacial atrophy, Cowden disease, then we have encephalocraniocutaneous lipomatosis and as well as epidermal nevus syndrome. These are the less common neurocutaneous markers or the neurocutaneous syndromes. Now, most of them, they are the inherited disorders. Either they are autosomal dominantly inherited or autosomal recessively inherited. Now, if you see this question, which of the following has autosomal recessive inheritance? Neurofibromatosis, tuberous sclerosis, Sturge-Weber syndrome, ataxia telangiectasia. Now, among all these, it is your ataxia telangiectasia which has autosomal recessive type of inheritance. So, right, these are the most common neurocutaneous syndromes, that is neurofibromatosis, tuberous sclerosis, Sturge-Weber, ataxia telangiectasia, and as well as linear nevus syndrome. Now, out of which, if you take the type of inheritance, your neurofibromatosis and tuberous sclerosis, both of them, they are, the type of inheritance is autosomal dominant type of inheritance, whereas Sturge-Weber syndrome, the inheritance is the sporadic type of inheritance. Ataxia telangiectasia, the type of inheritance is autosomal recessive type of inheritance, whereas linear nevus syndrome, it is the sporadic type of inheritance, right? And you take the cutaneous manifestations or the skin manifestations. In neurofibromatosis, the skin manifestations will be in the form of café-au-lait spots, then followed by that we have neurofibromas. It is axillary or inguinal freckling. So these will be the important manifestation in neurofibromatosis. Whereas in case of tuberous sclerosis, the cutaneous manifestations will be in the form of adenoma, sebaceum, then followed by that ash leaf spots, and the other cutaneous manifestations, they include shagreen patches and as well as the periungual fibroma. And Sturge-Weber syndrome, if you see, the cutaneous manifestation or skin manifestation will be in the form of a port wine stain, and that is nothing but facial angioma, right? And ataxia telangiectasia, mainly these individuals, they'll have telangiectasia as the name itself suggests, right? They have telangiectasias, and I'll show you that telangiectasias in case of ataxia telangiectasia. Whereas in case of linear nevus syndrome, you have nevus, that is sebaceous nevus will be there, and even acanthosis nigricans is also the other manifestation that you will have in case of linear nevus syndrome. So these are the types of inheritance, right? So mainly your neurofibromatosis and tuberous sclerosis, autosomal dominant type of inheritance, whereas ataxia telangiectasia, it is autosomal recessive type of inheritance. Now, out of which, let me take up the discussion of the neurofibromatosis. So, if you take this neurofibromatosis, we have two types. One is neurofibromatosis type 1 and as well as the neurofibromatosis type 2. So, you see a question here, chromosome abnormality in neurofibromatosis type 1 is, options are the chromosome 17, chromosome 22, chromosome 19 and then chromosome 14. So, the chromosome abnormality in case of neurofibromatosis type 1 is the chromosomal abnormality is on chromosome 17. Now, how can you remember or how to remember this? So, if you take this neurofibromatoses, so if you count the number of words, right, the number of letters in this particular neurofibromatosis word, it will be 17 number. So just please remember the chromosome 17 is the abnormality, right? Now, so I said you that this neurofibromatosis, it is of two types. One is neurofibromatosis type 1 and the other one is neurofibromatosis type 2. And the other name of this neurofibromatosis is oculo, that is eyes, neuro, that is CNS or brain, cutaneous, skin involvement will be there. Oculo-neurocutaneous syndrome, right, which is characterized by a multi-system involvement, right, which is characterized by a multi-system involvement. So, if you take the neurofibromatosis type 1, this is nothing but peripheral neurofibromatosis. Right, this will be peripheral neurofibromatosis. Whereas neurofibromatosis type 2, this will be central neurofibromatosis. And the neurofibromatosis type 1, that is peripheral neurofibromatosis, it is nothing but von Reckling-Hausen syndrome. right? So von Recklinghausen syndrome will be your peripheral neurofibromatosis, whereas central neurofibromatosis is bilateral acoustic neurofibromatosis. Right, bilateral acoustic neurofibromatosis, that will be neurofibromatosis type 2. Now between these two, which is most prevalent? Neurofibromatosis type 1, it is most prevalent, right? It is this neurofibromatosis type 1, it is seen in almost 90% of individuals, whereas among the neurofibromatosis type 2 will be only seen in 10% of individuals. And you should know on which particular chromosome you have this neurofibromatosis type 1 and type 2 gene. So you take this neurofibromatosis type 1 gene, this is present on chromosome 17, right? Whereas neurofibromatosis type 2, if you take this neurofibromatosis 2 gene, this is present on the chromosome 22, right? This is present on the chromosome 22. And both of them, let me tell you, the type of inheritance is the autosomal dominant type of inheritance. Right, both of them, the type of inheritance is autosomal dominant type of inheritance. So this is about the neurofibromatosis type 1 and as well as type 2. So type 1 is peripheral and as well as type 2 is central neurofibromatosis. Type 1 is von Recklinghausen syndrome and type 2 is bilateral acoustic neurofibromatosis. And the type 1 is more prevalent than compared to that of type 2. And the neurofibromatosis type 1 gene is present on chromosome 17, whereas type 2 gene, it is present on chromosome 22, and both of them, the type of inheritance is the autosomal dominant type of inheritance. Now let me take up the discussion of the neurofibromatosis type 1. So if you take the diagnostic criteria, so please remember the very important cutaneous manifestation in patients with the neurofibromatosis type 1 is you have the presence of the café-au-lait spots. I'll show you that café-au-lait spots. So the criteria in case of the neurofibromatosis type 1, the mnemonic is cave spot, right? The mnemonic is cave spot. So out of which, what does this particular C stands for? The word C stands for café-au-lait spots, and the word A is axillary or inguinal freckling, right? I'll show you this, axillary freckling. Whereas if you take the word F, F will be fibroma, and you take the word E, that is manifestations in the eye, that is leash nodules. And the word S will be the skeletal changes. And what will be that skeletal changes? That is, okay, bowing of the spine or bowing of the leg can be there. And the word P is positive family history. Right? And the word OT will be the optic tumor. Right? And this particular optic tumor will be glioma. Right? So this will be neurofibromatosis type 1 diagnostic criteria, right? The mnemonic for neurofibromatosis type 1, that is the cave spots. Now, like how many number of café-au-lait spots should be there, right? The number of café-au-lait spots should be minimum of 6, right? And what should be the size of that café-au-lait macules? The size should be around 5 mm. Right, the size should be 5 mm in prepubertal individuals. Right, in prepubertal individuals, the size is around 5 mm, whereas the size is around 15 mm in the post-pubertal individuals. Right, the size is around 5 mm in prepubertal and it is around 15 mm in the post-pubertal individuals. right? And axillary or inguinal freckling should be there. And coming to this leash nodules, I'll show you the leash nodules that you will have in the eye. And how many leash nodules should be there? There should be more than or equal to 2 leash nodules should be there as a part of the diagnostic criteria, right? And even you take this neurofibromas, the number of neurofibromas, F is nothing but fibroma. The number of neurofibromas should be more than or equal to 2 in number, right? 2 or more neurofibromas or 1 plexiform neurofibroma should be there, right? So this will be the diagnostic criteria. Now out of all these manifestations need not be there in the patient with the neurofibromatosis type 1. See, in case of neurofibromatosis type 1, at least 2 of the following should be present. That is café-au-lait spots, axillary or inguinal freckling, 2 or more iris leash nodules, 2 or more neurofibromas, then the bony lesions in the form of sphenoid dysplasia or the bowing of the legs, optic glioma, and as well as the positive family history, right? So these manifestations, there should be 2 out of these manifestations. And if you take the bony abnormality, I said you the bowing can be there. And the most common orthopedic manifestation in neurofibromatosis type 1 is your scoliosis, right? And this particular scoliosis is what? It is lateral bending of the spine, right? Lateral bending of the spine. That is what is your scoliosis, and that is the most common orthopedic manifestation of neurofibromatosis type 1, right? So this will be the scoliosis, right, where you have the lateral bending of the spine. Now followed by that, you see the cutaneous manifestations that I am showing you within the near the axillary area, but this is what I wanted to show you in this image, right? Axillary area, we have axillary freckling, like which I'll show you later. But what is this particular macule? This particular macule, it is a café-au-lait spots, right? And it is flat pigmented birthmark. And according to the diagnostic criteria, what should be the size of this? The size of this should be around 5 mm in prepubertal individuals, or the size should be around 15 mm in the post-pubertal individuals, right? Prepubertal 5 mm and 15 mm in the post-pubertal individuals, right? So that is about your the café-au macules or café-au spots. Now you see this pigmentations within the axilla, and what is this pigmentation? This is nothing but your axillary freckling, right? So this is your axillary freckling, right? And as the name itself suggests, it is present in the axillary region, that is armpit, and the increased number of freckles suggest the more severe disease, right? Suggests the more severe disease. And what is the description of this axillary freckling? They are small circular spots on the skin that are darker than the surrounding skin because of the deposits of the melanin. So what is there in this? Melanin is deposited. So how are these? These are small circular spots on the skin. Right, small circular spots on the skin because of the deposits of the melanin. So that is what is your the axillary freckling. Then the another image you see here, this will be the fibromas, right? And what fibromas are these? These are neurofibromas. Right, these are neurofibromas. So neurofibroma, it is a benign nerve sheath tumor. Right, it is a benign nerve sheath tumor in the peripheral nervous system. These are what is called as the neurofibromas. Then followed by that you take the ocular manifestations. So what is this ocular manifestation suggestive of? This particular ocular manifestation, it is suggestive of the leash nodules. Right, suggestive of the leash nodules. And these leash nodules, they are melanocytic hematomas, right? These are melanocytic hematomas that appear as well-defined dome-shaped elevation projecting from the surface of the iris, right? So these are well-defined dome-shaped elevation, right? Where exactly? That is from the surface of the iris. Right? So these are nothing but the leash nodules, right? And what will be the color? The color will be either clear to yellow or brown in color. That will be your leash nodules. Then followed by that, you take this important bony abnormality. This important bony abnormality is sphenoid dysplasia, right? Now, after having discussed about the various manifestations in neurofibromatosis type 1, you see this question. The commonest tumor in neurofibromatosis type 1 is optic glioma, neurofibromas, hematoma, sphenoid tumors. Let me tell you, among all these, the commonest tumor will be the optic glioma, right? So you can see this image here. So this particular MR imaging, it is suggestive of the optic glioma, right? So this is your optic glioma, right? Now, having said this, so the commonest tumor in neurofibromatosis type 1 is optic glioma. And these optic gliomas are present in approximately 15% of patients in neurofibromatosis type 1. Right? How common they are? They are seen in almost 15% of patients with neurofibromatosis type 1. And its presence is included as one of the criteria in establishing the diagnosis of the neurofibromatosis type 1. So, if you take the overall CNS neoplasms in neurofibromatosis type 1, the neoplasms, I'll just give you a mnemonic for this, right? The mnemonic is NMO-SAN, NMO-SAN, right? N stands for neurolemmomas, right? Neurolemmomas. The word M is meningiomas. Right? The word O is optic glioma or optic nerve glioma. Right? And this will be the commonest. Right? The word S is schwannoma. Right? The word A is astrocytoma. And the word N is your neurolemmomas or neurofibromas. Right? So these are the CNS neoplasms in neurofibromatosis type 1. Now, apart from the CNS neoplasms, you also have the other tumors with higher incidence than the general population. And these includes pheochromocytomas. Right? Pheochromocytomas, they are the tumors which are originating from the chromaffin cells of the adrenal medulla. Then rhabdomyosarcoma. Right, so this rhabdomyosarcoma, it will be the tumor originating from the muscle. And then leukemia, right, it is the tumor or the malignancy of the WBCs. Then Wilms tumor, that is the tumor originating from the kidney. Then we have juvenile xanthogranulomas. right? So these are the other tumors with higher incidence than compared to that of the general population, right? Now, after having discussed about the neurofibromatosis type 1, now let me take up the discussion of the neurofibromatosis type 2. So most common tumor in neurofibromatosis type 2, unilateral acoustic neuroma, bilateral acoustic neuroma, cerebellar hemangioma, optic glioma. So let me tell you, in neurofibromatosis type 1, right, your optic glioma, that was the most common. Whereas in neurofibromatosis type 2, please remember the word 2, letter 2 or number 2. That is, bilateral acoustic neuromas are very common, right? Neurofibromatosis type 2 and 2 acoustic neuromas, which is nothing but bilateral acoustic neuromas. These are the most common tumor in neurofibromatosis type 2. And at the same time, you should know what is the diagnostic criteria for the neurofibromatosis type 2. So diagnostic criteria is that, see, definitely there should be presence of the tumors, right? Definitely there should be presence of the tumors, and you should diagnose when any one of the following is present. Number 1, bilateral eighth nerve mass, right? Bilateral eighth nerve mass which is consistent with acoustic neuroma. Right, which is consistent with acoustic neuroma. So, if you see the diagnostic criteria of neurofibromatosis type 2, right, so the one which I am about to discuss, any one of the following should be present, okay. So, that includes number 1, bilateral eighth nerve masses should be there. Right, bilateral eighth nerve masses, and that too consistent with the acoustic neuromas. And this bilateral eighth nerve masses, that should be demonstrated by CT or MRI, right? That should be demonstrated by CT or MRI. Then followed by that, a parent, sibling or child with neurofibromatosis type 2 should be there. So family history of neurofibromatosis type 2, right? Because neurofibromatosis, it is your autosomal dominant type of inheritance, okay, right? So or mostly it should be bilateral eighth nerve mass. But for suppose if the individual is having unilateral eighth nerve mass, right, but for suppose if the individual is having unilateral eighth nerve mass, then in such case there should be any two of the following tumors. Right, any two of the following tumors should be there. What are those? Number 1, neurofibroma. Number 2, meningioma. Number 3, glioma. Number 4, schwannoma. Number 5, juvenile posterior subcapsular opacity. Right, so these are any two of the following should be there along with the eighth nerve mass. So to consider the diagnostic criteria of neurofibromatosis type 2, it is diagnosed when any one of the following is there. Right, it is diagnosed when any one of the following is there. That is about the diagnostic criteria of the neurofibromatosis type 2, right? So you can just remember this mnemonic also, that is Miss U. M stands for multiple, I stands for inherited, S stands for schwannomas, right? Multiple inherited schwannomas. And this schwannomas, it should be bilateral adenoma. Right, it should be a bilateral adenoma, and that should be consistent with acoustic neuromas which are demonstrated by the CT scan or the MRI, right? Or it should be unilateral adenomas, right? Or it should be unilateral adenomas with any of the two tumors. What of these? Any of the two, that is either neurofibromas, meningiomas, gliomas, schwannomas, and posterior subcapsular opacity, right? So that is about the diagnostic criteria for neurofibromatosis type 2, that is Miss U. M is multiple inherited schwannomas, unilateral adenomas, or any of the two of the following, right? And what are those two of the following? I have discussed. Now you need to remember the rule of 2 in case of the neurofibromatosis type 2. So the rule of 2, it is number 1, neurofibromatosis type 2, and next the chromosome which is being affected is the chromosome 22, right? Then followed by that there will be bilateral vestibular schwannomas, then followed by that it is present in the second decade and occasionally around even fourth decade as well. And next, the initial prevalence is estimated to be 1 in 2 lakh population. So that is about the rule of 2, neurofibromatosis type 2. The chromosome which is affected is 22, right? Bilateral vestibular schwannomas. Then it is present in the second to fourth decade. Now, these bilateral acoustic neuromas, they are the most characteristic tumors associated with neurofibromatosis type 2, while juvenile posterior subcapsular cataracts are one of the most characteristic ocular manifestation in patients with the neurofibromatosis type 2. Whereas in neurofibromatosis type 1, the most common tumor is optic glioma. Whereas in neurofibromatosis type 2, the most common tumor will be bilateral acoustic neuromas, right? And the most common ocular manifestation in neurofibromatosis type 2 will be juvenile posterior subcapsular cataract. Now, you see this question now. All of the following are the characteristic features of neurofibromatosis type 1 except acoustic neuroma, café-au-lait macules, pseudoarthrosis, scoliosis. The answer in this question is the acoustic neuroma. So, acoustic neuroma, it is the feature that you will see in patients with neurofibromatosis type 2. The café-au-lait macules, they are present in neurofibromatosis type 1 and even your pseudoarthrosis. So, right, cortical thinning of the bones with or without pseudoarthrosis, it is seen in neurofibromatosis type 1. And most common orthopedic manifestation will be the scoliosis. Now, you see another question. Schwannoma of the spinal nerve root is seen in neurofibromatosis type 1, type 2, Turcot syndrome, Lee-Fromani syndrome. So, the schwannoma of the spinal nerve root, it is seen in case of the neurofibromatosis type 1, right? And this particular schwannoma, it is a benign tumor arising from the Schwann cells. Right, it is a benign tumor arising from the Schwann cells of cranial and spinal nerve roots. Right? So that is what is the schwannoma. It's a benign tumor originating from the Schwann cells of the cranial and spinal nerve roots. Okay, and this neurofibromatosis type 2, it is your acoustic neuroma, which is very common. Now coming to your Turcot syndrome. See, what is this Turcot syndrome is? Turcot syndrome, it is characterized by the formation of multiple benign growths in the colon. Right, multiple benign growths in the colon, and these multiple benign growths in the colon, they are nothing but the polyps, right? And these multiple benign growths in the colon, they occur in association with primary brain tumor. Right, they occur in association with primary brain tumor. And these growths, they are associated with bleeding from the rectum. Right, these growths, they are associated with bleeding from the rectum. And not only that, the other gastrointestinal manifestations include diarrhea or constipation, right, and there can be also abdominal pain, and as well as the weight loss. Right, so these are the features of the Turcot syndrome. Then we have another point another option in the question, that is Leigh-Romanis syndrome. Now what is this particular Leigh-Romanis syndrome? Leigh-Romanis syndrome, it is an inherited familial predisposition to a wide range of certain often rare cancers, right? So you have certain wide range of rare tumors in this Leigh-Romanis syndrome. And this particular rare tumors in Leigh-Romanis syndrome, it is mainly due to a change in a tumor suppressor gene which is known as TP53, right? So tumor suppressor gene, that is TP53. So that is what is your Leigh-Romanis syndrome, right? Which is an inherited familial predisposition to wide range of certain often rare cancers. Then you see another question. Leash nodules are seen in which of the following conditions? Von Recklinghausen's disease, Lewy Bowyer syndrome, then tuberous sclerosis, von Hippel-Lindau syndrome. Now leash nodules, they are seen in case of the neurofibromatosis type 1, and this neurofibromatosis type 1 is nothing but your von Recklinghausen's disease, right? And I have said you already, it is mainly due to abnormality in the neurofibromatosis type 1 gene which is present on chromosome 17. Then what is this Lewy Bowyer syndrome? Lewy Bowyer syndrome, it is an alternative name for ataxia telangiectasia. Right, it is an alternative name for the ataxia telangiectasia. And in tuberous sclerosis, which is common in child, they have the hypopigmented macules, right? I will be discussing about the tuberous sclerosis, where you have the presence of the hypopigmented macules. Then von Hippel-Lindau syndrome, it is also present in child or in children, and these individuals, they have nystagmus. Right, so that is what is your von Hippel-Lindau syndrome. So leash nodules seen in neurofibromatosis type 1, which is nothing but your von Recklinghausen's disease. Right, now among the neurocutaneous syndromes, what all we have discussed until now? We have discussed about the neurofibromatosis. So that is type 1 and type 2. Type 1 is your von Recklinghausen's disease. Right, Now, then followed by that, let me take up the discussion of this von Hippel-Lindau syndrome. So you see this question now, what is the hallmark feature of the von Hippel-Lindau syndrome? The options are craniospinal hemangioblastomas, cerebral hemangioblastomas, pancreatic hemangioblastomas, more than 7 hemangioblastomas. So the hallmark of von Hippel-Lindau syndrome will be craniospinal hemangioblastomas. Now, and at the same time, you need to know what is the inheritance of this von Hippel-Lindau syndrome. Let me tell you, this particular von Hippel-Lindau syndrome, it is a rare autosomal dominant type of inheritance. Right? The type of inheritance is autosomal dominant type of inheritance. And in these individuals, you have abnormal angiogenesis. Right, there is abnormal angiogenesis where the individual will have benign and as well as malignant tumors. Right, the individual will have benign and malignant tumors, and these are present at multiple sites within the individual. And what is the hallmark of this von Hippel-Lindau syndrome? The hallmark feature of the von Hippel-Lindau syndrome is craniospinal hemangioblastomas. Right, so these are the hallmark feature of the von Hippel-Lindau syndrome. And these hemangioblastomas in von Hippel-Lindau syndrome are often multiple in number, and most frequently they are found within the cerebellum. Right, they are present within the spinal cord and as well as the brainstem. So this will be the distribution of the craniospinal hemangioblastomas. Right, now you see the various manifestations in von Hippel-Lindau syndrome. Like, let me just give you a mnemonic of various manifestations or various tumors. The mnemonic is the car peep. You are peeping through a car, and the word C stands for cerebellar hemangiomas. Then the word A is angioblastoma, that is retinal angioblastoma. Then followed by that you take the word R. R will be renal cell carcinoma, and the word P is the pheochromocytoma. Then followed by the word E. E is ependydymal nodule and tumor. Right, ependydymal tumor. Then the word E is endolymphatic sac tumor. Right, and the word P will be pancreatic endocrine tumor. Okay, so this is what is your CAR PEEP, that is cerebellar hemangiomas, retinal angioblastomas, and the other R is renal cell carcinoma, and PEEP, P is pheochromocytoma, E is ependydymal nodule and tumor, E is endolymphatic sac tumor, and the other P is pancreatic endocrine tumor and cyst. So that is what is your CAR PEEP. Now you see this individual is having this renal cell carcinoma, right? This individual is having renal cell carcinoma. So, patients with renal cell carcinoma, there is excess production of the erythropoietin, and this excess erythropoietin production by the hemangioblastomas, right? This excess erythropoietin is by either renal cell carcinoma or by hemangioblastomas, right? This excess erythropoietin will increase the erythropoiesis, and that will make the individual to develop polycythemia. Right, that will make the individual to develop polycythemia. So polycythemia is a characteristic associated feature in von Hippel-Lindau syndrome, and that is due to erythropoietin produced by hemangioblastomas or the renal cell carcinomas. And this von Hippel-Lindau syndrome, the type of inheritance is the autosomal dominant type of inheritance, right, wherein you have hemangioblastomas and as well as the other tumors, right? Already I have said you in the mnemonic, that is CAR-PEEP. So, if you take the clinical spectrum, you have the hemangiomas or the hemangioblastomas. And where will be the distribution of this particular hemangiomas? That is you have capillary hemangiomas of the retina, right, capillary hemangiomas of retina or optic nerve head, right? So that will be the hemangiomas. These hemangiomas, they are with or without tumors, cysts and polycythemia, and these particular tumors, they include hemangioblastoma, right? These tumors, they include hemangioblastomas, right? And this may be either cerebellar tumors or spinal cord tumors or medullary tumors. Then followed by that, the other tumors will be renal carcinoma and then the pheochromocytoma. And what are the cysts? These particular cysts include the renal cysts or pancreatic cysts or hepatic cysts or ovarian tumor, right, or pulmonary cysts, right? So these will be the cysts in case of, these are all the clinical spectrum in case of the in case of von Hippel-Lindau syndrome, and even the presence of polycythemia. And why polycythemia is there, already we have discussed, right? And you take this cerebellar, among the tumors, I said you hemangioblastomas, right? That too craniospinal hemangioblastomas. And among the cranio, that is cerebellar hemangioblastomas, they are very important. Let me tell you that this cerebellar hemangioblastomas, they are a benign neoplasm that occur either sporadically or as a part of the von Hippel-Lindau disease. And the clinical presentation is with, because of cerebellar disorder, the individual will have the features of cerebellar dysfunction, right? Or the individual will have hydrocephalus, right? And polycythemia. And why is that polycythemia? That is due to production of erythropoietin, right? So this will be the features of the von Hippel-Lindau syndrome. Now, even if you take the diagnostic criteria, I said you the most common CNS tumor of von Hippel-Lindau will be the craniospinal hemangioblastomas, and out of this craniospinal hemangioblastomas also it is cerebellar hemangioblastomas. See, until now whatever we have discussed, neurofibromatosis type 1, most common tumor is optic gliomas. Neurofibromatosis type 2, bilateral acoustic neuromas. Von Hippel-Lindau syndrome, right? The most common CNS manifestation will be the cerebellar hemangioblastomas. Okay. So the diagnostic criteria, if you take the central nervous system and as well as retinal hemangioblastomas, then hemangioblastomas and at least one of the following: renal, pancreatic, hepatic, epididymal cyst, pheochromocytoma or renal cell carcinoma, and there should be family history as well. So if you see this question now, most common tumors in von Hippel-Lindau syndrome are infratentorial, supratentorial, infra and supratentorial in the sella turcica. Most common tumors in von Hippel-Lindau syndrome, what are they? They are cerebellar hemangioblastomas. And where are they located most commonly? Most commonly they are located in the infratentorial area, right? Most commonly they are distributed in the infratentorial area. Now you see this. In neurofibromatosis type 1 and type 2, the most common distribution will be supratentorial and infratentorial area, right? It is present in the supra and as well as the infratentorial location. And Sturge-Weber syndrome, right, it is in the supratentorial location. Whereas in von Hippel-Lindau, most common location will be infratentorial then compared to that of supratentorial. Whereas in tuberous sclerosis, which is nothing but Bonville's disease, it is supratentorial only. So in Sturge-Weber syndrome and sclerosis, Sturge-Weber syndrome S, supratentorial S, sclerosis, that is tuberous sclerosis S and supratentorial S. Whereas neurofibromatosis type 1 and type 2, it is both supra and as well as infratentorial. And von Hippel-Lindau syndrome, please remember it is infratentorial more than compared to that of the supratentorial. Right, so that is about the distribution of the neurocutaneous syndromes. Next, now you see this question. An 8-year-old boy has a mental retardation. On examination, he is found to have well-defined kidney lump. CT scan shows a well-defined hypoechoic lesion in the kidney and multiple lesions in the liver showing density of -50 to -80 Hounsfield units. What is the probable diagnosis? Autosomal recessive polycystic kidney disease, tuberous sclerosis, von Hippel-Lindau syndrome, paraganglioma. So the answer here, it is not your von Hippel-Lindau syndrome. The answer here is the tuberous sclerosis, right? The answer here is the tuberous sclerosis. Now we will take up one by one. You take the autosomal recessive polycystic kidney disease. Okay. In autosomal recessive polycystic kidney disease, the very important feature is the mental retardation or the seizures. Right? Mental retardation or seizures is not seen in the clinical scenario of the patient. Now, so after having discussed about the von Hippel-Lindau syndrome, now let me take up the discussion of the tuberous sclerosis. So in patients with tuberous sclerosis, you have the presence of the hypopigmented macules. Right? So these are the hypopigmented macules which are present, and along with this hypopigmented macules you have the presence of seizures and as well as mental retardation. So these three, if they are being present in an individual, suggestive of the tuberous sclerosis. And in case of tuberous sclerosis, you have multiple manifestations. And let me just give you a mnemonic. Hamartomas are one of the manifestations in tuberculosis. And let me just give you a mnemonic, that is the hamartomas. Right? And the word H will be hamartoma. Right? And the word A is adenoma sebaceum. Right? And the word M will be mental retardation. Right? And now properly this mental retardation, now it is being referred as the intellectual disability. and the word A will be ash leaf spots, right, and the word R will be rhabdomyoma, right, and the word T will be tubers, that is cortical tubers. The word O will be optic hamartoma, right. The word M will be mitral regurgitation, and the word A will be astrocytomas, right, and the word S will be seizures or shagreen spots. Right, so these are your hamartomas, right? So out of which hamartomas, which is a tumor originating from the skin, which I will be discussing. So if you take the cutaneous manifestation, the cutaneous manifestation will be in the form of the hypopigmented macules. I have just shown you that. And this particular hypopigmented macules, they are called as the ash leaf spots. And these hypopigmented macules or ash leaf spots, they are present in almost more than 90% of cases. And what will be the shape of these particular, the hypopigmented macules or ash leaf spots? These are small, right, and they are ovoid, and these are scattered, right, these are scattered and variable in number. That is what is your hypopigmented description of hypopigmented macule or ash leaf spots. Then the other cutaneous manifestation, if you see, that is the presence of the shagreen spots. These particular shagreen spots, they are roughened, raised, leathery lesions, right, they are roughened, raised, leathery lesions with an orange peel consistency. That is what is your shagreen spot. Then followed by that we have adenoma sebaceum. This adenoma sebaceum, they are facial skin hamartomas. Right, they are facial skin hamartomas that develops in early childhood. And how do they appear? They appear as tiny red nodules. Right, they appear as the tiny red nodules over the nose, right, over the nose and cheeks. And this will resemble the acne. That is what is your adenoma sebaceum, right. Then followed by that periungual fibroma. So these particular fibromas, they are present over the face and they are also present over the fingers, right. And these particular tumors, that is periungual fibromas, they are more common in the toes, that is in the lower limbs, then compared to that of the fingers of the upper limbs. And this particular tumor, they are called as the Quinan's tumor. Right, they are called as the Quinan's tumor, right. So that is about the periungual fibromas. Okay, next. So these are, yes, so this will be your facial angiofibromas. So previously I have shown you the periungual fibroma and this will be the facial angiofibromas. Okay, so these are the cutaneous manifestations that you will come across in patients with the tuberous sclerosis, right. These are your cutaneous manifestations. Then followed by that, you take the neurological manifestations in patients with the tuberous sclerosis. See, these particular neurological manifestations, that will be in the form of the seizures. You have a triad, right? You have a triad. Let me discuss all the neurological manifestations. These neurological manifestations, the most common will be the seizures, right? Seizures will be the most common presenting symptom. And what type of seizures these individuals will have is infantile spasms, right? Infantile spasms. So infantile spasms will be there. That will be the form of the seizures. And then mental retardation. Mental retardation, it occurs in up to 50% of patients. And whereas seizures, it is present in almost 70 to 80% of individuals, right? And patients, particularly with seizures, right? Patients with seizures are more prone to mental retardation, okay? So that will be the neurological feature. And there is a characteristic brain lesion. And this particular characteristic brain lesion will be a tuber. And what will be that particular tuber? That is a cortical tuber. And what will be the most common neurological manifestation? That will be in the form of the seizures, right? And apart from the seizures, there is also cognitive impairment and behavioral abnormalities. Right? Cognitive impairment and as well as the behavioral abnormalities. Right? So these are the neurological manifestations that you will see. And even in the imaging also, so when you do, so this will be your cortical tuber. And when you do imaging, what does this imaging shows? The imaging in these individuals, it will show you the presence of subependymal nodules with calcification, right? Subependymal nodules with calcification on neuroimaging is a characteristic neurological manifestation. Then, apart from this, so we have discussed cutaneous manifestations, then we have discussed the CNS manifestations. Then you need to know what are the other features. The other features include the renal lesions, and these particular renal lesions will be in the form of renal cysts or angiomyolipomas may occur. Right, angiomyolipomas may occur, right? And these renal lesions, they are bilateral, right? They are bilateral and they are often multiple, right? They are often multiple. And even cardiac lesions are there, that is rhabdomyomas of the heart may occur. Right, rhabdomyomas of the heart may occur. And if you take the pulmonary lesions include the cystic lung diseases may occur, or the lymphangioliomyomatosis is classical pulmonary lesion. Right, lymphangioliomyomatosis. And the lesion within the eye, that will be retinal hamartomas. Then the skeletal lesions, if you see, that will be cystic rarefaction of the bones or the fingers or the toes. Okay, so cystic cystic rarefaction of the bones or the fingers or the toes. So this will be the skeletal lesions. So renal lesions will be in the form of renal cysts or angiomyolipomas may occur, and that too bilaterally, and often they are multiple in number. Cardiac lesions will be in the form of rhabdomyomas. Pulmonary lesions will be in the form of lymphangioliomatosis. Eye lesions will be in the form of retinal hematomas. Skeletal lesions will be in the form of cystic rarefaction of the bones or the fingers or the toes, right? And you see this question now. The classical triad described in tuberous sclerosis includes all except. It includes seizures. It includes mental retardation. And it also includes the adenoma sebaceum. But it does not include the cerebellar hemangioblastomas. These cerebellar hemangioblastomas, they are very common, right? They are very common in case of von Hippel-Lindau syndrome, right? That is what we have discussed, okay? Right? So, where do you suspect, right? Where do you suspect this tuberous sclerosis? Tuberous sclerosis should be suspected in any child presenting with unexplained seizures. Right? Any child with unexplained seizures who shows hypopigmented cutaneous macules. That will be your tuberous sclerosis. And tuberous sclerosis is characteristically associated with subependymal giant cell astrocytoma, right? So let me just show you this SEGCA, okay? That is SEGCA, subependymal giant cell astrocytoma, right? Now, what is this subependymal giant cell astrocytoma? Let me just give you the description of this. Let me tell you, it is a low-grade, non-infiltrating, benign tumor of the, so basically it is the tumor originating from the astrocytomas, right? Right? It is an astrocytoma, okay? And it's a benign variant of astrocytoma. That is what is your subependymal giant cell astrocytoma. And they are characteristically but not always associated with the tuberous sclerosis, right? So they are seen in patients with the tuberous sclerosis, but it need not be always. And it occurs most frequently in patients with autosomal dominant type of the tuberous sclerosis. And the most common site of SEGCA is the ependymal wall of the lateral ventricle. So, where will be the most common site? That will be ependymal wall of the lateral ventricle. That will be the most common site of the SEGCA. And where exactly across the ependymal wall of the lateral ventricle? That is near the foramen of Monro. Right, that is near the foramen of Monro. That will be the common site of this particular SEGCA, that is subependymal giant cell astrocytoma. So as the word itself tells you, it is a tumor. It's a low grade non-infiltrating variant of astrocytomas, right? And they are characteristically seen in patients with tuberous sclerosis, but it is not always. And the common site will be the ependymal wall of the lateral ventricle near the foramen of Monro, right? And these tumors, they tend to grow towards the foramen of Monro, and they can cause the obstruction of this particular CSF flow, resulting in obstructive hydrocephalus, right? Resulting in obstructive hydrocephalus. That is what is your SEGCA, right? And pathologically, the lesions, they are composed of, which one? The SEGCA lesions, they are composed of the giant cells. And if you take the radiographic appearance, I'll just show you the radiographic appearance of subependymal giant cell astrocytoma. So you see this we call it as the candle dribbling appearance, right? This we call it as candle dripping appearance. right? This is called as candle dripping appearance. Okay, next, and these tumors, they occur predominantly in children around the first decade, right? Around the first decade, and they are essentially benign tumors. Okay, and how do you treat this SEGCA? The treatment of choice will be the gross resection, right? The treatment of choice will be the gross resection. That is what is your subependymal giant cell astrocytomas, right? And what will be the most common site for your subependymal giant cell astrocytoma? That is ependymal wall of the lateral ventricle near the foramen of Monro. Now, you see this question. Which of the following is not seen in tuberous sclerosis? Giant cell astrocytoma, white matter migration lines, subependymal nodules, ependymoma. Let me tell you, these individuals, they will have subependymal giant cell astrocytoma, but they don't have this ependymoma, right? Ependymoma is not the feature seen in patients with the tuberous sclerosis, right? So now let me just show you major features and minor features. Already we have discussed all. Mainly we have cutaneous manifestations, neurological manifestations, and other features. These three will be the tuberous sclerosis, right? And if you take the major features, that includes facial angiofibromas, periungual fibroma, hypomelanotic macules that should be more than 3, shagreen patch, multiple retinal nodular hematoma, cortical tuber, subependymal nodule, subependymal giant cell astrocytoma, cardiac rhabdomyoma, lymphangioliomyomatosis, and then renal angiomyolipomas. So these are the major features of tuberous sclerosis. Then you take the minor features. That includes the presence of pits in the dental enamel, and within the rectum there will be hamartomatous rectal polyps, and within the bone there will be presence of the cysts. And within the white matter of the brain, you have the presence of migration lines. And within the gingiva, you have the presence of the fibromas. Within the eye, you have retinal achromic patch, confetti skin lesions, and then multiple renal cysts. So these are the minor features of the tuberous sclerosis. Now, out of these major and as well as minor features, what should be the diagnostic criteria? It is not that all the cutaneous, all the neurological, all the other features should be there. So, diagnostic criteria, we classify this into definite tuberous sclerosis and then possible tuberous sclerosis. Definite tuberous sclerosis, 2 major features or 1 major plus 2 or more minor features. Okay, 2 major or 1 major plus 2 or more, right, 2 or more minor features will be there. That will be definite tuberous sclerosis. Then what do you mean by this possible tuberous sclerosis? Possible tuberous sclerosis is either 1 major feature or 2 or more minor features. Right? So this will be the diagnostic criteria for the tuberous sclerosis, definite and as well as the possible tuberous sclerosis, right? Now, you see a question on von Hippel-Lindau. All of the following are true about von Hippel-Lindau syndrome except multiple tumors are uncommon, hemangiopericytomas are seen in craniospinal axis, supratentorial lesions are seen, then tumors of the Schwann cells are seen. So, which of the following is not the feature of the von Hippel-Lindau syndrome? Von Hippel-Lindau, you don't have the multiple tumors. Multiple tumors are uncommon. So these individuals with von Hippel-Lindau, they have predisposition to bilateral and multicentric retinal angiomas, and then these individuals will have CNS hemangioblastomas and as well as renal cell carcinoma, pheochromocytoma, islet cell tumors of the pancreas, endolymphatic sac tumors, multiple tumors are present in case of von Hippel-Lindau syndrome. Okay, so multiple tumors are multiple tumors, they are common in patients with the von Hippel-Lindau syndrome, right? Now, out of all these, which is more common? That is CNS hemangioblastoma, that is cerebellar tumor, right? That is cerebellar tumor. And hemangiopericytomas in the craniospinal axis will be there. And what about supratentorial lesion? Let me tell you, actually in case of von Hippel-Lindau, infratentorial is very common, but even supratentorial will also be present, right? Even supratentorial will also be present, and tumors of the Schwann cells are definitely seen. So infratentorial lesions are common then compared to that of the supratentorial lesions, right? And what is that infratentorial lesion? That is cerebellar hemangioblastomas, right? That is cerebellar hemangioblastomas. So that completes the discussion of your von Hippel-Lindau and as well as the tuberous sclerosis. So now you see here what all we have discussed. So we have finished neurofibromatosis, we have finished the tuberous sclerosis, we have finished the von Hippel-Lindau disease. Now coming on to the Sturge-Weber syndrome, right? You see this question on the, okay, you see a patient with the Sturge-Weber syndrome where you have the presence of the nevus, right? And this Sturge-Weber syndrome, it results from the anomalous development of a primordial vascular bed. Right, it results from the anomalous development of primordial vascular bed during early stages of cerebral vascularization. During early stages of cerebral vascularization, right? So that is what is your the Sturge-Weber syndrome. And you take the leptomeninges. Leptomeninges, they are richly vascularized and brain beneath the vascular bed, it becomes atrophied, right? So brain beneath the vascular bed. And where is this vascular bed? This particular vascular bed is present in the leptomeninges, right? These leptomeninges, they are richly vascularized. And now what is this Sturge-Weber syndrome? It is anomalous development of vascular bed in the leptomeninges. And that vascular bed in the leptomeninges, they will cause the atrophy of the brain beneath, right? They will cause the atrophy of the brain which is present beneath this leptomeninges, right? And not only atrophied, they are also calcified. Right? Atrophied and calcified. So that is what will happen in case of the Sturge-Weber syndrome. And you have the presence of a characteristic nevus, and you can observe this is the vascular bed, and beneath that the brain, it gets atrophied. That is a characteristic feature in patients with the Sturge-Weber syndrome. And please remember this mnemonic of the Sturge-Weber syndrome, that is Sturge. The word S will be seizures, right? And the word T will be tram track calcification, right? And the word U will be unilateral port wine stain, right? Unilateral port wine stain. The word R will be retardation. The word G will be glaucoma, right? And the word E will be presence of epilepsy. Okay, so these are the clinical features of the Sturge-Weber syndrome, right? The seizures, tram track calcifications, I'll show you the imaging, unilateral port wine stain and weakness. Not only port wine stain, there will be also weakness because of the cortical atrophy. And this particular weakness, it is usually on the opposite side because the corticospinal tract, it will cross onto the opposite side. And R is your mental retardation and G is glaucoma, E is epilepsy. So these are the clinical features of the Sturge-Weber syndrome. So if you take the hallmark of Sturge-Weber syndrome, seizures, hemiparesis, mental retardation, glaucoma. The hallmark of Sturge-Weber syndrome is the seizures, right? Now, after having discussed about the mnemonic on the Sturge-Weber syndrome, let me discuss few points about this facial nevus, that is the port wine stain. So this port wine stain, it is present since birth and it tends to be unilateral and it always involves the upper face and as well as the eyelids, right? Always involves the upper face and as well as the eyelids, and may also involve the lower face, right? May also involve the lower face and mucosa of the mouth and pharynx. That will be the cutaneous manifestations. And neurological manifestations, the hallmark feature, right? The hallmark feature will be the seizures. That will be the characteristic neurological manifestation. And this neurological manifestation, seizures, it is present during first year of life. And what type of seizures are those? These include tonic-clonic seizures, right? These include tonic-clonic seizures, okay? Next, and these tonic-clonic seizures, they are present contralateral to the side of the facial nevus. And the other feature is the hemiparesis. And even this particular hemiparesis, it is present on the contralateral to the side of the facial nevus. And next, mental retardation. And these individuals, the ocular manifestations also will be there. And these ocular manifestations will be glaucoma, right, which is characterized by raised intraocular pressure, right? And there can be also even ophthalmos. So these will be the neurological manifestations in patients with the Sturge-Weber syndrome. And if you take the skull radiograph will show you intracranial calcification, right? Will show you intracranial calcification in the occipitoparietal region. And you also have railroad track appearance or serpentine appearance. I'll show you that image, right? Railroad track appearance or serpentine appearance. And CT scan, if you do, that will show you the presence of unilateral cortical atrophy of the brain. And why is that? That is because of the primordial vascular bed which is growing abnormally within the leptomeninges, right? And there is also ipsilateral dilatation of the lateral ventricles, right? Ipsilateral dilatation of lateral ventricles. And this CT scan will also show you what is the extent of the calcification, right? So this is about your Sturge-Weber syndrome, right? So this will be your facial nevus, right? And exactly opposite, you have the contralateral weakness or contralateral hemiparesis, and you also have the tonic-clonic seizures. And this will be, right? So this will be the serpentine appearance or railroad track appearance in the X-ray skull of the patients with the Sturge-Weber syndrome, right? And this will be the CT scan wherein you can see or you can observe the cortical atrophy. And you can also make out that there is ipsilateral dilatation of the lateral ventricle within the imaging, right? So this is about the Sturge-Weber syndrome. So to summarize, right, It is the disorder characterized by the portwine nevus over the trigeminal distribution characteristically. There is ipsilateral leptomeningeal angiomatosis, contralateral hemiparesis, seizures, mental retardation and congenital glaucoma. So these will be the features of your Sturge-Weber syndrome, right? Now, after having discussed about the Sturge-Weber, let me now tell you or discuss about another important form of the neurocutaneous marker, that is ataxia telangiectasia. All are the features of ataxia telangiectasia except cerebellar ataxia, telangiectasia, IgA deficiency resulting in recurrent chest infection, anemia. So, the features that you will not see in case of ataxia telangiectasia will be anemia will not be there. Then, if you take about the ataxia telangiectasia, see, neurofibromatosis, one Hippel-Lindau disease, they are all autosomal dominant type of inheritance. Whereas ataxia telangiectasia, the type of inheritance is autosomal recessive type of inheritance. And it is caused by a defect in the ATM gene. Right, defect in the gene called as the ATM gene. And this particular ATM gene encodes for DNA repair enzymes. Right, encodes for the DNA repair enzymes. Which one? The ATM gene. And this ataxia telangiectasia, it is one of the inherited combined immunodeficiency disorder. Right, inherited combined immunodeficiency disorders. Right, and this ataxia telangiectasia, it typically presents in the early childhood. Right, it typically presents in the early childhood with, right, with abnormal movements. Right, that is what you see in case of the ataxia telangiectasia. And apart from this, right, the characteristic feature will be ataxia. And that too, what type of ataxia is this? That is cerebellar ataxia. Right, that is what you will see in case of the ataxia telangiectasia. And there is also telangiectasias. What are telangiectasias? They are spider angiomas. Right, these are the other features in case of ataxia telangiectasia, and that will be cutaneous manifestation. And these individuals, they also have immunoglobulin A deficiency. And because of this immunoglobulin A deficiency, these individuals, they are prone for recurrent chest infections. Right, they are prone for recurrent chest infections. And 10% of individuals of this ataxia telangiectasia, they are at risk of developing malignancy. Right, and they are at risk of developing lymphoma. They are at risk of developing leukemia. Right, so that is about your ataxia telangiectasia. And these are your telangiectasias, which are nothing but the spider angiomas. Now, there is a lot of correlation between ataxia telangiectasia and we have another important ataxia, that is Friedreich's ataxia. Right? What is the common correlation? Both of them, they are autosomal recessive type of disorders. Both of them, they have cerebellar ataxia. Both of them, the onset is within the childhood. Whereas in ataxia telangiectasia, these individuals, they have spider angiomas or telangiectasias. They have IgA deficiency due to which they have recurrent infections. And there is increased risk of lymphomas and leukemias. And the onset is at the age group of 1 to 5 years. And when you compare this with the Friedreich's ataxia, This particular Friedreich's ataxia is mainly due to a trinucleotide repeat disorder, because of which there will be frataxin gene mutation. And apart from cerebellar ataxia, in Friedreich's ataxia, the individual will have lateral and forward bending of the spine, that is kyphoscoliosis, and there is degeneration of the optic nerve resulting in optic atrophy, cardiac manifestation in the form of hypertrophic obstructive cardiomyopathy, diabetes mellitus, and onset at the age of 10 to 15 years. And another form of cardiomyopathy is these individuals, they also have dilated cardiomyopathy. So these are some of the important correlating and differentiating features between the Friedreich's ataxia and as well as the ataxia telangiectasia. Now you see this question. A 6-year-old child with port wine stain, mental retardation and recurrent focal seizures, all are true about the condition except optic nerve cupping, tram track appearance on the X-ray skull, vagal nerve stimulation, hemangioma. Let me tell you, optic nerve cupping will be there, right? Optic nerve atrophy will be there, or optic nerve disc cupping will be there. Now, then followed by that, you take the tram track appearance of the skull. Why is this? This is due to the intracranial calcification, right? This is due to intracranial calcification, which on the X-ray skull produces the tram track appearance. Okay, and this optic nerve cupping, it is mainly due to the congenital glaucoma that you come across in these patients with the Sturge-Weber syndrome, and the vagal nerve stimulation. What is the purpose of this vagal nerve stimulation? That is for treatment of refractory focal seizures, right? Refractory focal. See, what are these focal seizures? They are the tonic-clonic seizures that you see on the contralateral side of the facial nevus, right? On the contralateral side of the facial nevus. So that for that you need to give the vagal nerve stimulation, because these individuals, they are refractory to medical management. So vagal nerve stimulation will be definitely useful. But this hemangiomas, the fourth option, if you take hemangiomas, they are not the features that you will come across in patients with the Sturge-Weber syndrome, right? Next, followed by that, if you take the differential diagnosis of the Sturge-Weber syndrome, we have a syndrome called Hippel-Lindau syndrome. In Hippel-Lindau syndrome, you also have the presence of the port wine stain. But here, in case of Hippel-Lindau syndrome, the port wine stain, it is present on the extremities. You can see that here, right? The port wine stain is present on the extremities and as well as the face. And one more differential diagnosis for your port wine stain will be your Beckwith-Wiedemann syndrome. So in case of Beckwith-Wiedemann syndrome, it consists of the facial port wine stain, and there will be also, right, there will be also macroglossia, there will be omphalocele and visceral hyperplasia, right? Omphalocele and as well as, yes, so this will be your omphalocele, right? Omphalocele and as well as visceral hyperplasia. So this will be your Beckwith-Wiedemann syndrome. Now, you see another question. A 48-year-old man with history of seizures has presented with gross hematuria and left flank pain. Abdominal CT reveals the left periphrenic hematoma with 3 cm angiomyolipomas along with multiple right renal angiolipomas measuring around 1.5 to 6.5 centimeters. Now, what will be the most likely diagnosis? The most likely diagnosis in this patient will be the tuberous sclerosis, right? It will be the tuberous sclerosis. See, these patients with tuberous sclerosis, they have the seizures and they have renal angiomyolipomas. These renal angiomyolipomas, they can bleed, right? They can bleed, okay, leading to perinephric hematoma, right? There will be hematoma formation surrounding the kidney. That is what you will see in patients with the tuberous sclerosis. And you see another question. Tuberous sclerosis, it is associated with all except Ashleigh macule, shagreen patch, schwannoma, adenoma, sebaceum. Let me tell you, this schwannoma, it is the feature of the neurofibromatosis type 2, and that is not seen in case of the tuberous sclerosis, right? Skin manifestations, they are characteristic in tuberous sclerosis, and almost in 90% of them, you have the presence of this ash leaf macule or the hypopigmented patch. That is what the features that you will see in tuberous sclerosis. Next, a child presents to the casualty with seizures. On examination, an oval hypopigmented macule were noted on the trunk along with subnormal IQ. Probable diagnosis of the child is neurofibromatosis, Sturge-Weber syndrome, tuberous sclerosis, incontinentia pigmenti. So, seizures, hypopigmented macules, then subnormal intelligent quotient. All these are suggestive of, all these are suggestive of the tuberous sclerosis, right? So in tuberous sclerosis, the another name of it is neurocutaneous disorder, neuro seizures, cutaneous hypopigmented macules. And this tuberous sclerosis, the type of inheritance is the autosomal dominant type of inheritance, whereas you take this incontinentia pigmenti. Incontinentia pigmenti, it is an X-linked, right? It is an X-linked dominant disorder, right? And what will be the characteristic skin manifestations? You have a wart-like rash, right? You have the presence of a wart-like rash, and you also have the presence of blistering or the blisters. Then followed by that, the diagnosis of a patient presenting with seizures, mental retardation, adenoma sebaceum, right? So this is a direct question suggestive of the tuberous sclerosis, right? And next question is, brain tumor is associated with all except tuberous sclerosis, von Hippel-Lindau syndrome, neurofibromatosis, Sturge-Weber syndrome. The answer is Sturge-Weber syndrome. So here you don't have a brain tumor. It is a tumor which is originating from primordial vascular bed in the leptomeningeal, right? You don't have a brain tumor in Sturge-Weber syndrome. Whereas in tuberous sclerosis, von Hippel-Lindau, neurofibromatosis, you have the presence of the brain tumor. So these are some of the questions related to the topic of the neurocutaneous markers. This is a very, very important topic from the neurology point of view. So with this, I'll wind up this very important session, that is neurocutaneous syndrome. Thank you very much.